to part one. So today we're going to be talking about understanding the cognitive cerebellum's role in ADHD and ASD. And I think this is a super important topic because I see it a lot clinically where you kind of think something's going on with the cerebellum with coordination issues, whether it's with learning disorders or motor function, and they have the ADHD, and you're thinking, well, what else do we need to bring on board? So I'm grateful for this presentation today to learn more. So for those of you who don't know Dr. Contractor already, it's great to have her here. She's a friend, colleague, and somebody who inspires me as well. But her credentials are that she's a board certified psychiatrist that blends both traditional and integrative psychiatry. She was trained at Western Psychiatric Institute and Clinic and has a passion for working in trauma, adolescent mental health, and cultural psychiatry. She spent over a decade at Kaiser Permanente, where she developed programs for at-risk youth, and her personal challenges have led her to really diving into the field of integrative medicine. And today she brings with her two esteemed colleagues as well, because as we know, a lot of times with integrative psychiatry, it's a multidisciplinary approach. Nobody can be the village by themselves. That's one of the best lessons I've learned in practice is I cannot know everything, but if I can know the person who knows, that is really powerful. So she's working along with Dr. Brian Tierney, who's a somatic psychologist, neuroscience professor at California Institute of Integral Studies, and a psychotherapist dedicated to integrative healing. He specializes in trauma resolution, couples therapy, and somatic work, and he combines cutting-edge science with timeless practices to create transformative healing experiences. You can check out his podcast, Boundless Body Podcast, which I had, and it's a great podcast to look into. And he's the author of the upcoming book, Visionary Somatics. So welcome to you both. And I will have Layla tell us a little bit about Anahita, and then we can get started.
I'm actually going to have Anahita talk about Anahita because I feel like she'll do a much better job. But as I was putting together, Brian and I were putting together the presentation, I just felt like I was talking so much about sensory integration therapy, and I had a bit of imposter syndrome, feeling like, why should I be the one talking about it? So Anahita is an extremely talented sensory integration OT. She actually treated my children. And I actually consider the therapy she did, it would be an understatement to say it was life-changing. She actually changed the trajectory of my youngest daughter's life. But I want her to talk a little bit about her training and why it's really, important to look for somebody who is trained in sensory integration, because that is truly a specialty of its own within OT.
Thank you, Layla, for that very kind introduction. I am an occupational therapist for almost 25 years now. And from the beginning, I had advanced training in sensory integration therapy. I'll touch to it later on in the presentation towards the end regarding the different types of background an OT can have. But just to kind of precedent just for the current audience, finding a provider that has background in ears sensory integration therapy is really quite different, and it's an advanced practice beyond just the doctorate program for OTs.
Anahita has, Darwell has her own private practice where I think she's really become like our expert in Orange County in treating older. I mean, we're used to, 0 to 3 OT, but she treats older people, quite skilled in treating even adults who are on the spectrum. And she's had at least decades worth of experience within the school district. So she is a real, quite extremely experienced. The second case I have is with an 8-year-old female that Anahita also saw, who was diagnosed with being on autism spectrum disorder. She also had central auditory processing disorder, dyslexia, and she met criteria for expressive language delay. And what I noticed through videos that, I would have sent is that in engaging in sensory integration treatment, it was like a different kid. All of a sudden, this kid who we thought really couldn't express very much, all of a sudden, you know, started having full range of affect, ability to, you know, express emotions, but also discuss them. And we saw significant improvement in reading levels. So as an 8-year-old was in 2nd grade, reading at a kindergarten level, and very quickly caught up with other interventions as well. But I would say that the sensory integration piece allowed the other interventions to actually be very successful. And so I will, Anita will talk more about that, but I will pass the baton to Brian, who's going to talk to us more about the scientific basis for why this is.
Hey, everyone.
Brian? There you go.
Yeah, good to hear that there's some Midwesterners afoot. You know, I'm from St. Paul, Minnesota. So I'm stuck out here in Silicon Valley now. It's a good place though. So yeah, in my Visionary Somatics book, I go into cerebellar functioning at length. Okay. Now, as a trauma specialist, what I've discovered clinically and through my research, that the cerebellum is essential, like in terms of the treatment of trauma, that the cerebellum is an essential structure to interface with. So, you know, basically the long and short of it is, if the cerebellum, and if you know about the precuneus, I don't know if any of you have heard about the precuneus. It's a peculiar little hub in the brain that has to do with, it's part of the vestibular network, as is the cerebellum. These two structures, the precuneus, which has a lot to do with spatial consciousness, spatial registration, proprioception. If the precuneus and the cerebellum are not lit up, then the trauma resolution process will not work. Okay, so, you know, as you know, the cerebellum is a major hub for processing saccades. Okay, the little twitches that our eyes are constantly doing. Okay, constantly doing, and then the cerebellum has to essentially put all of those twitches and into a coherent sequence being the key word here, of you know, like a topographical map. It needs to put it into order. Okay, so one of the things that clinically shows up regularly with a traumatized body is unsequenced eye movements. Okay, if you can just kind of go through your clinical file folder and think about your highly traumatized patients, what you'll probably remember is that when they get triggered, their eyes start going all over the place. Okay, their eyes start going all over, and then so what are we doing? We're doing grounding techniques. We're trying to, you know, basically get them grounded. But from a cerebellar functioning perspective, what's happening is that the cerebellum has lost its ability to do its core job, which is to sequence the core processing neurology. Okay, in terms of sensation, vestibular and proprioceptive information, and eye movements. Okay, but as we start to talk about the cognitive cerebellum, there's all sorts of social sequencing that the cerebellum has been found lately to do over the last 20 years. Okay, so so I go on and on and on about the cerebellum. It's crucial. The cerebellum is crucial, and thinking about it now and offering it as a framework that, you know, from an integrative perspective, that when we're doing our clinical work with people, we're doing various types of resequencing, using different languages and different clinical techniques. Okay, so when I'm working with a heavily traumatized person, I'm working directly with the eyes, helping them to ground. And then as a psychotherapist, of course, I'm doing narrative resequencing. Okay, narrative resequencing. So this is, folks, this is direct work with the cerebellum. And I'm packaging it like this because it's a true integrative hub. It's 600 million years old. Cerebellum is like 600 million years old. So it's a subcortical structure that's doing very advanced things. And this is the latest research. Okay. What else to say about visionary somatics? It's also got a kind of well, the two forms of depth psychology that are known about by most of us, right, are Jungian depth psychology, the work of Carl Jung and his approach to the unconscious, and of course the Freudian unconscious. What's under talked about, and I don't know if any of you have heard about this, is the Lacanian unconscious, the genius Jacques Lacan, and the whole French branch of psychoanalysis. Okay, so this is an understudied and very important approach to the unconscious. And so and the technical jargon term is called semiotics, a semiotic approach to the unconscious. And what that means is essentially, yeah, a kind of deep mapping of how humans make meaning. Okay, and it's kind of slightly more surrealistic than Freud or Jung, but I think it's the most scientifically accurate. So, so I go at length into what's called biosemiotics. Okay, this is complex stuff and important stuff. So, the book is hard. Okay, originally I was I was under contract to write an easy book for, what are your 5 points for beginning somatic psychologists, and I realized that I just couldn't do it. I just couldn't do it. I was just too bored with it, and so I just let it blast. And so I talk about semiotics and evolutionary psychiatry and evolutionary biology. I go into embryology of all things. And it really is a work of integrative psychology. It is very deep and a very difficult book. But in terms of trauma neuroscience, I really want to claim that this is a true update to the neuroscience because, if any of y'all know about the default mode network, okay, raise your hand if you know about the default mode network a bit. Okay, there's a lot of talk about the default mode network, and one of the important things to know about the default mode network is the cerebellum is a core structure within the default mode network. Okay, you have to do the deep dive into the literature to find this out, but it is very, very true. In fact, there's 9 subnetworks within the cerebellum, 9 subnetworks that hook up to other networks within the brain, and it really is truly our champion for an integrative hub. It really is the cerebellum. Okay, it cuts across our professions in a very deep and profound way. And then biophysics, as I said, easy book. All right, so can we go to the next slide? Okay, so this puts it in a nutshell. Okay, folks, so let's start, rather than reading this thing first, I'm going to say 2 words to put cerebellar functioning into a nutshell. Predictive sequencing. Predictive sequencing. And this cuts deep, folks, just these 2 words. Okay, this is what our narrative apparatus does. It's what the default mode network does in kind of collaboration with the cerebellum. It does predictive sequencing, okay? And with trauma, that sequencing gets disjointed. With sensory processing disorders, okay? We have a disjointed cerebellar processing, i.e. things cannot be put into sequence. With autism spectrum disorders, we have a disjunction in narrative sequencing and theory of mind, okay? These are sequencing issues. Okay, so the cerebellum and then when we're thinking about the cerebellum insofar as the cognitive, the more evolutionarily advanced aspects of the cerebellum, that's when we encounter phrases like this. The cerebellum tweaks and refines thoughts, images, and ideas, just as it refines and smooths motor movements. Okay, so that's a great phrase for the advanced, more evolutionarily new aspects of the cerebellum. Okay, if you compare the volume of the human cerebellum to the neocortex in the prefrontal regions and the neocortical structures, we have about 80%. The cerebellum is about 80% of the volume of the entire brain. Okay. And then if you compare that to macaque monkeys, okay, cerebellum is about 30%. of the entire volume of the brain. So it is very evolutionarily advanced, even though it's 600 million years old. So I call it the ancient new, because it does ancient sequencing, and now it's doing all this advanced stuff socially and kind of sensory integration hub at a very advanced narrative meaning making level. Okay. Let's see here. So, and another phrase that I'd like to throw out there in terms of cerebellar functioning is another two words, okay, that are central: noise cancellation. Okay. It is a deep hub for learning, folks. So raise your hand if you've heard the term efference copy. Anybody heard the phrase efference copy? Okay. So the cerebellum is a bit, we could think of it like imagistically or metaphorically, and this is more than a metaphor, this is actually informed by the science, as an echo chamber of learning. Okay, so sensory flows come up through the thalamus and go to all association areas of the brain, except for smell, of course. And then each time there's a flow through the thalamus and through the basal ganglia, a copy gets sent to the cerebellum for refinement. That's called an efference copy. Okay. And so the cerebellum is like this mega library of sequences, okay, and adaptive filters that is running all of these efference copies through and looking for errors and holding it in a library to kind of like compare old sequences with new sequences. For example, you trip over a log, you're going for a walk, trip over a log, okay? And the cerebellum is learning from the past trips, whenever you've tripped, to kind of rapidly come back into sequence with your gait. Okay. And it's like this immense library. And then at the end of the day, what does it do? It does noise cancellation. Okay. Based on a whole library of learning from sequencing. Okay. Now the next slide is really brings us into the radical implications, clinical implications of cerebellar functioning with autism spectrum and auditory processing disorders. So let's go to the next slide. So, okay, so let's just focus on the first two words. They're technical words, but very important words. Okay, developmental diaschesis. Okay, so this principle basically means that the earlier that the cerebellum is damaged, either embryologically or in the first 3 years of life, the more radical the implications are for downstream psychopathology, downstream processing disorders. And we see just incredible statistics. So as I've said, the cerebellum is a library of sequences. That's one way of thinking about it. And in the early accumulation of this library of sequences, if the developmental process has been derailed, we see major downstream consequences. So this is an incredible statistic here. So if a person in the early phases of development has a damaged cerebellum, either embryologically or elsewhere, they have a 40-fold increase in developing an autism spectrum disorder. 40 times more likely. Okay, so this is just incredible. When I ran into this, I was like, oh yeah. So it really highlights, what we've been talking about with Layla's daughter. This makes early intervention crucial. Why? Because the cerebellum is accumulating its great library of sequences. And if it doesn't, and if it's still derailed developmentally and there isn't extra support, then we're going to have we're going to lose critical windows and critical time frames for brain development. And you see this major, just mind-blowing growth in the third trimester, where you have cerebellum expands by 30 times. And so there is some significant evidence that Purkinje cells, the primary processing unit of the cerebellum, are deeply impacted by endocrine disrupting chemicals. Okay, no surprise to y'all being integrative clinicians, right? So, there's the implications for ASD are really widespread in terms of endocrine disrupting chemicals, how it messes with the endocrine switching and stuff like that in terms of embryological development. That is most definitely part of it, as is birth trauma. Okay, as is birth trauma. Very common to get cerebellar injuries because of all that stuff happening near the occiput, during birth and all the medical intervention and all that stuff. So, it's for you osteopaths out there that, cranial touch and stuff like that. This is where the classical stuff really does apply, treating those cerebellums as early as possible. Okay, I'll pause there for now. Is there any questions or comments? Amelia?
I have a question. So if it's very common as you're talking, it's making me connect two pieces in my mind. There's a lot of patients who have a great deal of developmental trauma will complain of dizziness, constant dizziness. And so I'm curious, what kind of treatment does one get if now they're out of the trauma, but they're still dizzy? They go to the ENT. The ENT said, "There's no reason I can understand why you're dizzy." What do you do?
Yep. So the network neuroscience, so default discovery of the default mode network was the beginning of a paradigm shift in neuroscience, okay, into what's now called network neuroscience. Okay. So the default mode network, salience network, and the task network, but there's like 12 networks that are talked about now. And one of them is the vestibular network. The vestibular network. So what we have is a vast network of neurons where the cerebellum is a major hub, the precuneus is a major hub, hippocampal grid cells, major hub, okay? And so this vestibular system, this vestibular network gets thrown out of joint. It gets disjointed in trauma, or especially early developmental trauma. And so it's no surprise that the core processing of the vestibular system is thrown out. So how do you work with that? You work with the orienting reflex. The orienting reflex is the reflex that has to do with the neurology and the musculature of your neck, the neurology of your eyes. And as I said, with trauma, often what we're seeing is those eyes and those saccades are not sequenced. The saccades are not sequenced. Cerebellum is not sequencing the saccades. Okay, so that means eye movement. So EMDR, folks, I go on and on about it in the book that EMDR is good for some things and not good for other things. Okay, with radical trauma and complex trauma, not good. Why? Because the resequencing is too fast. If you've ever done EMDR, it's quite fast, right? For radically traumatized bodies where the orienting reflex and the vestibular system is deeply thrown off, that is just too fast. Okay, so but we still need to resequence the saccades and the eyes, and we need to resequence how the brain is doing proprioception. How do we do that? Okay, slowing things down. Easier said than done. Slowing things down, easier said than done, right? People speed up and get unsequenced, but we want to get that orienting reflex online. So, similar to how you brought us out of meditation, hey, let's slowly look at objects in the room. Let's bring that person into the left hemisphere functioning so that they're needing to, because trauma is right lateralized in the brain. So we want to get into the narrative, Broca's area. We want to put together the orienting reflex with left hemispheric processing. Leaning towards good memories. Okay, one of them that I like is, okay, I know that they have a dog or a cat. Can you remind me what the name of your cat is? So they have to, the energy and information is kind of turning towards the left hand side of the brain. Can be very important sometimes to reflect their awareness to their limbs, because the limbs, in terms of vestibular processing, when there's a trauma history and proprioception, that the limbs are commonly the first things to shut off neurologically. The felt sense of the limbs in space. So directing awareness to the feet. Now, of course, this is where we get into the complex narrative sequencing part of the cerebellum. Research shows that, and in somatics, this is one of the shadows or one of the limitations, that we almost assume that uh, coming into the body and feeling the body is going to be resourcing for people and grounding. That's a bad assumption, especially with somebody that has one of these, does the noise cancellation function just isn't working. We have this kind of flooding dynamic that Layla was talking about. That is not going to help some people to go into their body. In fact, what we found in the trauma literature is starting from a third person perspective is where to start. The third person perspective, witnessing your body from the outside, witnessing a trauma memory from the outside, rather than just jumping into proprioception. Because why? Because it's unsequenced and flooded with noise. So how do we reduce the noise? This is where the art of being a clinician comes in, sure, informed by science, right? But we got to get that system slowed down. We need to self-regulate ourselves because trauma is contagious. We engage with that orienting response, and if they don't go bonkers when we get them into reading out the sensory process in their limbs, then we would start with the limbs. Otherwise, go into third person tracking it. I could just go on and on about the importance of third person tracking and like how I do it, but that's in the book, and maybe we can talk about it another time.
I just wanted to say one more thing too. Is this, Amelia, to piggyback off your thing? Literally every single patient I have that has developmental trauma has a sensory process. It could, be diagnosed with sensory processing disorder. And I think this speaks to that. And even I would have to say, even as an adult, if people have had, prolonged traumatic experiences, their whole sensory processing system is off kilter. And one other thing I wanted to say, I totally agree. EMDR seems to work for single incident traumas, for developmental trauma, where it's so much more complex and there's so many incidences and micro incidences. It actually seems, it can really, I've had several clients come who have been actually, their trauma has become worse after engaging in EMDR. So I just wanted to say that.
For sure. Yeah. Well, there's another slide, right? Is there one more slide, I think? Yeah, and then there should be, if you do another click, there'll be a quote that shows up. So just wanting to show to you, this is more like you take a moment to read this stuff, how widespread and how deep and how complex cerebellar processing is. I mean, just take a look at this stuff. There's mirror neurons in the cerebellum, if you've all heard about mirror neurons. So it's a hub for empathy. I mean, this was just not known 20 years ago, right? It's a major hub within the default mode network. It's doing narrative sequencing, language processing, it's CODs, auditory processing, putting things into sequence, right? So I'm wanting you to kind of like understand as a noise cancellation hub, and its function is like learning sequences. I want you to kind of generally understand clinical phenomena that we're talking about in terms of auditory processing, ASD, the lack of theory of mind, and ability to do expressive language coherently and receptive language coherently. This is a cerebellum issue that cuts across. It really does cut across clinical phenomena. Okay. And then so I'll just end with this quote here. Is a wonderful quote, and I'll just close with that. Cerebellum plays a crucial role in identifying sequences in movements and actions, which gives humans the social capacity to observe intentions in movements, i.e. mirroring, or to attribute mental states in others, i.e. mentalizing or theory of mind, and making predictions about imminent or future social behavior. So that all comes back to what we started with, predictive sequencing. Predictive sequencing is off, it's disjointed. We need to resequence it with sensory tools like what Anita will be talking to us about and what we've talked about. That we need to engage directly with the vestibular system. Okay, and then when I'm working with ASD patients, I am doing narrative resequencing. Okay, and that would take me a while to unpack like how I do that. I mean, I just can't, I need 10 minutes for that, and the time is limited, so. But let's just stick with the sequencing, and it's effective, it's working. It works well. And I'm working directly with the vestibular system and with the cerebellum. Yeah. All right. End of transmission.
Muted. This just underscoring what Brian already said, which just really how important the cerebellum is. Again, 10% of brain volume, but 75% of our neurons in that area. You know, traditionally in medical school, we're taught that really the cerebellum is really just about balance and coordination. But as he said, it's a network. It's actually a network. It works with the vestibular system to coordinate balance and physical movement amongst many, many other things. Dr. Schimmelmann is actually a neurologist at Harvard who actually has Schimmelmann syndrome named after him. He did a lot of research on when stroke affects the cerebellum. And even from that, we've understood a lot of the importance of cerebellum functioning for many things. But what he notices in his patients who have cerebellar strokes, it's what he calls the dysmetry of thought, right? So thoughts are disjointed. But he also noticed that these patients had a lot of emotional lability. And it goes back to Brian's other side of like how important the cerebellum is in even just our emotional processing and sequencing. In ADHD, we see a much smaller vermis. And as Brian mentioned, the cerebellum is highly neuroplastic, which is why so many of the early interventions, especially 0 to 3, can be really helpful. But as we know, neuroplasticity, I mean, we're beginning to understand much more how much neuroplasticity we have, much more time than we thought, and can continue, which is why even the, you know, teens and adults that Anita sees really benefit from sensory integration work. And this is just, I just wanted to show just a brief study that they've actually done with ADHD and balance. And those kids did much better than just methylphenidate alone. And balance would be just a very kind of crude explanation of what, you know, Anita does. But there, again, even in our own psychiatry literature, there's starting to be a better appreciation of how this needs to be. And not just, oh yeah, we put them, yes, sports are important, but there's, I'm going to let Anita talk much more about why it's important to be very skilled and precise about what you're addressing in this network. And I'll pass it to you, Anita.
Thank you, Dr. Contractor. Just to give you all a little background in error sensory integration therapy and how that will differentiate from what you'll see many other clinicians do that looks like sensory motor. And I'll just refer to those two broad categories in that, yes, if a child does sports, if they do balance training, there's a lot of things out in social media that for sure there'll be a benefit. And that goes back to what Dr. Tierney also speaks regards in terms of the cerebellum, the vestibular network. When we talk about error sensory integration therapy, Dr. Jean Ayers taught at USC back in the 1960s, did a lot of the preliminary work in the neuroscience and the connections to the learning disabled population, and the theory has evolved over the decades and how its impact is. And there's level 1 randomized controlled studies done at a Thomas Jefferson University with Dr. Roseanne Schaff about its effectiveness with the children on the spectrum. And there's just a wide body of research that continues to grow in this area. And really it looks at, as Dr. Tierney talked about, how the cerebellum is an important part of this, and it is a network. So the sensory integration therapy is really founded on There is a fidelity measure. If you wanted to provide more information on the chat, there's a fidelity measure of how this intervention looks. You need advanced practice in specifically this treatment method and how to provide it in the efficacy manner. And it really looks at the vestibular, the proprioceptive, and the tactile systems, and how those are the three core senses and how they integrate. And that's how the art of the assessment and the treatment is based on the theory of how to provide these. And it goes from the brainstem to the cerebellum. We can keep talking about the limbic system, reticular activating system. It is a network. And when done with fidelity, and you will really see that our brains are so complex, right? You will see the outcomes in so many methods and so many multiple means. So if we go back to the case studies to kind of wrap this together, the first child, she was an infant, and really seeing her, I would see her intermittently at social events, and I would see her lack of movement and her lack of awareness of her environment. And those were the clues to me. Her low muscle tone. There were so many layers. So when in terms of diagnostic purposes, you wouldn't just look at one variable and say, oh, this is indicative of a sensory integration concern. There are standardized tools now as young as under the age of 4 to be able to assess and identify a sensory integration concern. And based upon that, then you would know the right treatment methods. And sometimes sensory integration therapy isn't the method of choice. So it really depends on the complexity of the situation. As Dr. Tierney spoke to, is there a level of trauma involved? Whether there's layers of trauma with someone who has other developmental needs. What I have found clinically over the years, as in the first case, is there's layers. There's layers to every human, and to understand the complexity of those layers and which ones are more foundational at that time in their development to address those first, or you want to do another treatment method first and then layer something second, or do we do them simultaneously? And then it's, as you all know, as psychiatrists and physicians, when you have multiple treatment methods, which many of us do simultaneously with patients, it's hard to determine, well, which one was it a combination effect? Which one was truly the intervention that really we see that sudden or even gradual improvement with. So with the going back to the first case study, there were multiple between her emotional regulation, from the reflexes, as Dr. Tierney talked about, and as a therapist, I think we all have different within our specific areas, different nomenclature of what we refer to it. So if we call it within the field of sensory integration therapy, we'll call it the vestibulo-ocular reflex. And that is a big part of what we do in the sensory integration therapy for many individuals, I find, especially related to their development and their in the education system. And this is one way that I tie into the second case study, where the reading improvement made by the second child. And a lot of students that get referred to me may not be diagnosed on the spectrum, may not be diagnosed classically as ADHD, or even and they're just having a little difficulty concentrating or copying from the board, or their handwriting looks a little sloppy. And when you do proper assessment, you will see that there is this foundational area of concern with vestibular, ocular, vestibular proprioception, the tactile system, or a combination of them all. And it's really critical to tie it all together to help that trajectory move forward and support the child. So what I have on this slide is just the most current relevant systematic review of randomized control trials out there for air sensory integration for the 0 to 12 population. This was just released like 2 months ago. And I want to speak to how this is where sensory integration therapy was developed for this originally between 0 and 7 months. A lot of the neuroplasticity was talked about, and how, and really now as neuroscience is evolving, we're seeing how if there's no neuroplasticity throughout life, and this intervention is child directed, and it does look play like within the specialized equipment. And so the theory will evolve, in my humble opinion, I've applied it to older populations, adolescents, young adults. It does not look within the fidelity measure as first described, with Dr. Ayers. However, it can be very effective in supporting adolescents, even young adults in their growth, whether we want to call that development or their neurodevelopment. Their different nomenclature, in my opinion. And the second link down below refers to just kind of that. There's a lot of literature and textbooks out there regarding sensory integration therapy, but this is just one reference to some of an article from some of the really prominent people within the field who are doing a lot of the heavy research about the neural foundations of sensory integration therapy. Are there any questions?
I think one question everyone is going to have is, how do we find somebody local who does this kind of therapy? Is there a database we can go to and look?
There is a database growing. If you want to look up CLASI, CLASI, they will have a network of providers. I know there are some, they're trying to develop a lot of, like Dr. Malo, Dr. Suzanne Smith-Rowley, Dr. Schaff, who are all really prominent in the field. They have helped to create this what they call as CLASI. And they're doing the AIRS sensory integration certifications through that. You can do a certification through a couple of other places. It used to be just through USC, University of Southern California, where Dr. Ayers did practice in the 60s and developed the theory and the treatment and the assessment method. Another good resource would be if you look up SPD, and it would be the work of here. Oops, sorry, if you can go back, Layla. Thank you. If you of Lane, if you look up, she would also out of Denver, they had sensory processing disorder. It comes, that term specifically comes out of Denver, and there's a lot of great work that's done out of there, as well as in Boston. So, and if you look up Teresa May Benson, she has a lot of work done as well. All these providers here at this bottom list, if you were to Google any of their names, they have heavy research. They have, a lot of them have their own practices, or they teach at universities.
And I would have to say, especially with the younger kids who come in, like we have the 4-year-olds who are being kicked out of like 3 preschools, the first thing I do is to really refer them to sensory integration OT. And many of these patients actually won't come back for medicine. But I think it's really a crucial intervention we can offer for really young ones, where we know they're going to probably struggle with either taking the medicine, or, the stimulants are just, they have too many side effects on those things. And it may not be actually the appropriate diagnosis. That might not actually be what's going on with them, but it looks like ADHD, and it's something people are more, familiar with. But I really heavily rely on this for also the younger kids. And with the older kids that I send, I see so much improvement in mood regulation. I think all of these things allow us to use no medicine or way less medication.
I've had, and just to piggyback on that, I've had so many kids at the age of 4 or 5 come to me on multiple medications, and they have a list of diagnoses, including autism, ADHD, some even bipolar, many diagnoses. And what I've learned throughout the years is do a thorough assessment. And what I often would find, there is some sensory processing concern, and I would do my part and address that concern. And it was interesting to see the progress in the development of the child, whether it be from simple things in my mind, where it's a motor coordination, to their emotional regulation. And once you have that motor and that emotional regulation, it impacts a person's self-esteem. It impacts a person's confidence in themselves and how they then differently engage in their world, and their social relationships change. So it is, as you, this is the right crowd. You all know how it's all linked together and neurologically, and it's so vital and important that this work is done at that younger age, because as we then, when it's not addressed in a younger age, and then development continues to happen, and then it starts to manifest maybe as an adolescent, as an anxiety disorder. And then I have had many individuals just refer to me with not just, but in an anxiety type disorder. And when you start to unpack it, they'll talk about how all the different sensory things they need to do in their day. And it looks like sensory strategies or coping skills, where they need a fidget, they need to rock. And then if you unpack it, and if you try to give a modified lifestyle of different activities they can do to engage and try to remediate what they couldn't, needed to be remediated at a younger age, there can be good progress, as they need less strategies, less maybe even medication to cope and have that appropriate regulation in life.